the accumulation that you see very clearly in the other picture here.
So this is the macular area of the patient.
Yes.
So that means this patient has
Macular edema.
Macular edema. So the vision is
Well, usually the vision becomes very poor with these types of swelling.
But is there treatment for?
Yes, there is treatment. Currently, what we use for macular edema is intravitreal anti-VEGF injections.
Okay, we will explain that later. Okay, so basically, this is a picture of a fluorescein angiogram, and this is the OCT of this normal eye,
center part,
and this is an example
of an abnormal
OCT of an abnormal patient with diabetic retinopathy or macular edema. Okay, so if a patient has like this, proceed to the retina specialist or to the eye doctor. Okay, so next slide. Now we go to treatment. So we've discussed the diagnostics. Now we see the whole picture. You have diabetic retinopathy. So how do we go about the treatment, Dr. Jimenez?
Well, if it's non-proliferative, usually strict diabetic control and control of other diseases like hypertension is enough.
Well, let's go first to non-proliferative. So non-proliferative means, are there any other stages in the non-proliferative, like mild, moderate, severe?
Yes, you're right. No, mayroong mild, moderate, severe, and very severe. We usually reserve laser treatment for very severe or early proliferative.
Early proliferative.
So if your doctor says that you have mild, moderate, or severe, usually medical treatment is enough.
Is enough. Medical treatment means?
Means it's strict diabetic control, control of hypertension, if any, control of diet, exercise, and if you have anemia also, you have to cure that anemia. And you may take supplements for diabetes also.
Should you have a referral to an endocrinologist?
Of course, it's best that a diabetologist sees you.
Okay, so because what happens if you're treating the patient and then the patient doesn't take care of his blood sugar?
Well, if you, for example, do laser on a patient with diabetic retinopathy and the blood sugar is not controlled, that patient can develop retinopathy again.
Okay.
So bleeding might recur and he might still end up getting blind.
So treatment doesn't mean that it's enough.
That's right.
So you have
to cure the root of the problem, which is diabetes.
Diabetes. So what's happening in the eye is actually what's happening in the whole body. So if you have diabetes mellitus, meaning in the whole body, in the eye it's just a manifestation. So when you treat the manifestation, so if the whole body is not being treated with the diabetes, it can come back.
That's right.
Okay. So next slide. Oh, okay. This is
this is a picture of a retina that underwent laser treatment. The white spots that you see here scattered all over are laser scars, and actually there's some hemorrhages there,
yeah.
bleeding. This picture was taken immediately after laser treatment. Later on, the laser scars will become grayish or black.
Grayish and dark, or black. Okay. So, why do we do laser, Dr. Jimenez? What's the laser for?
Well, basically, it's to decrease the metabolic load of the eye, to decrease the oxygen requirement, thereby decreasing the chances for proliferation or new vessel formation that can lead to more complications. Well, that's the theory behind it.
So you only laser patients who are very severe non-proliferative
or early
proliferative. Okay, so if you have mild, moderate, severe, still diet, exercise,
yes.
The usual blood sugar control.
Well, of course, there are exceptions. Exceptions.
Okay. Next slide, please.
The second treatment option that we have is injection of anti-VEGF. Now, VEGF
what is anti-VEGF?
Vascular endothelial growth factor. There are many brands. These are one of the more popular brands that we inject inside the eye. We reserved injection for those with diabetic macular edema because studies have proven that it's very hard to treat macular edema with just drops alone. So
and laser.
And laser.
Yeah.
So this is an adjunctive treatment for that kind of
So who can do this injection? Can the regular ophthalmologist do the injection, or
Well, it's best.
because me, I refer all my injections to Dr. Jimenez.
Of course, it's better to have the injection done on those who have experience.
So that means the
Basically,
retina
those
specialist.
retina specialists.
Okay, so that's good. So this is your patient, the eye with the macular edema. You inject the dye inside the eye, and that will usually clears up.
That's right.
Okay.
Usually, it takes about a day or two to see results with injection.
Okay, very
But
good.
sometimes it can take more than one
Mhm.
injection. This is not without complications. So before you decide to have the injection done, your eye doctor should explain all the possible complications to you.
Complications, yeah, because it's still an injection. Okay. Next slide, please. Okay, this is actually our last slide, no? Now, when laser fails or the anti-VEGF fails, or even though if you don't do them, it's already advanced. So this, I think, this is the only option, no?
Very frequently, we see patients who present to us with late-stage
Late
diabetic
stage.
retinopathy. Laser, unfortunately, cannot be done. Intravitreal injection cannot be done. So what we offer them is surgery. Surgery for diabetic retinopathy is called vitrectomy. And usually, when membranes have developed already inside the eye, we take out the membrane, so membranectomy. And if there are holes or detachments inside the eye, secondary to those membranes, we repair the holes, do an air fluid exchange, and do laser treatment, or add silicone oil or inject gas. So it's a little complicated,
Actually,
but
it's not a little. It's more complicated.
it's very complicated.
More
but
complicated.
Diabetic retinopathy, especially the later stages, are very complicated. That's why, as much as possible, we do not want diabetic retinopathy to progress.
Yeah, because
So you want to catch them early, so the treatment is easier, more simpler, and more cheaper.
yeah. So actually, if you have a patient with diabetes, if you have a patient with diabetic retinopathy, actually that patient is your patient for life, no? Because most of these patients are already in their 50s or 60s, and then they're going to have diabetes. They should have regular follow-up. That's right.
That's right.
So for us, not for the patients not to be blind, they have to really have a strict follow-up, strict control of diabetes, so that they won't have laser injection or surgery. Is that right? Okay. So, wow, the episode is so fast, no? In fact, it's they're already telling me it's already the end of the show. So, Dr. Jimenez, any parting words to our audience?
Diabetic retinopathy is one of the top causes of blindness in Filipinos.
How about in the States?
In the States, in the elderly, it's macular degeneration. But in the Philippines, I think, well, from experience, I think it's diabetic retinopathy.
Okay.
And you must remember, diabetic retinopathy is a lifestyle disease, especially those that present later in life in the elderly. Unlike in juvenile diabetes, type 1. So most of the diabetes that we see can be controlled or prevented by a healthy lifestyle, diet, exercise. So, but if you do have diabetes, if you have relatives with diabetes, please remind them to see an endocrinologist, if you can, and ask for a referral to an eye doctor if your diabetes doctor has not made a referral yet, because you want to make sure that your patient or your relative does not develop complications of diabetes inside the eye, because when the complications get worse, or if they present too late, it's very hard to control. They end up usually getting blind.
Okay. Well said, Dr. Jimenez. Thank you again for
Thank you, Dr. Henson,
gracing our episode today. And that's our episode, Diabetic Retinopathy, here in All About Vision. Good day, and see you in our next